mess people out, it's like, oh, okay. I'm just going to say I don't really mind if I offend you guys. Every time I've learned or grown in my life, it's because I've been really uncomfortable, and learning and growing sucks. And most of the things that I'm going to talk about today were hard-won with a lot of pain and uncomfortableness. So I hope that I can help you all feel very uncomfortable today. Before I begin my presentations, I always like to acknowledge that the land that we're standing on belongs to Indigenous people. A couple facts that I found when I looked up were some of the people that used to live here before invasion and colonization were the Iroquois, who were not an individual tribe, they were actually a confederation of a bunch of tribes. And another one was the Shawnee, who were forced to assimilate into the Cherokee Nation for the convenience of the European colonizers for about 100 years before they were allowed to separate and reclaim their identities. So this is a little bit about me. My pronouns are she, her, they, them. I am a white person. I've tried just about every drug, never considered my use a problem. I don't use any illicit drugs anymore, and I'm pretty sad about that. I felt like I was a lot healthier and happier when I had a little bit more freedom with that. I tend to use alcohol more than I used to now. I don't have any desire to procreate, and I'm mentioning these things because a lot of times people ask me, why are you so passionate about this? And they assume that I must have this terrible, chaotic drug use history or have children or something. I want to help everybody else have children. I don't have any desire myself. Like she said, I've got 14 years experience in hospital perinatal care, 8 of those as an RN. I have 8 years experience in a peer-run syringe access program in Seattle. And I'm on those boards. I question everything, even when it comes from organizations that we're all really used to trusting, like AAP and ACOG, because a couple times I've been reading things and I've said, that seems fishy. So I will follow up on it, and it seems fishy because it is fishy. So question everything and do your research, your own research. Goals of this presentation, I want you all to be able to define harm reduction. I want you to be able to understand destigmatizing language. I'm not just going to talk about opioids today because substance use doesn't occur in a vacuum. Most of the people that we're seeing are going to be polysubstance users. Most of us are polysubstance users. In the last 24 hours, I've used NSAIDs and caffeine and nicotine and a little bit of alcohol too. So those are 4 different substances that I've used for various purposes in the last couple of days. We're also going to talk about NOW treatment techniques. I use that term, we'll talk about that in a second, newborn opioid withdrawal. I'm hoping that each of you will be able to think about and describe your own personal role, responsibility, and duty in dismantling the war on drugs. And then we're going to go over a little short list of resources, if there's time. So, harm reduction can be applied to anything, and it should be applied to everything. Harm reduction is seatbelts. Harm reduction is birth control and LARC and condom use. Harm reduction is going to sleep early before you have a big day. It's so broad that it can literally be applied to anything. The Harm Reduction Coalition defines it as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Now notice that's not caused by drug use, associated. That's an important distinction. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. That's another extremely important piece. So, harm reduction begins with language. Language is something that signals to your patients how you feel about them and whether or not you respect them as people or whether that that's an addict, shall we say. The correct diagnosis from the DSM-5 is person with substance use disorder. Addiction is not a medical term any longer. It's archaic. It means different things to different people. If you ask 10 people on the street what addiction is or what an addict is, you will get 10 different results. So it's not very helpful to use as a term because it means so many things that it's practically become meaningless. Value neutral language is it's very subtle, but it makes your tone so much better and so much less alienating to people. So rather than saying to your patient, well, the consequences of your drug use are this, you can just say the effects. Because let me tell you, they don't need to feel any more guilty than they already do. Another thing that I want to include that's not particularly related to substance use is your language should be inclusive. There's, by some estimates, about 40% of young people these days identify somewhere along the LGBTQIAA and on spectrum. So we're going to be seeing a lot more trans men carrying pregnancies to term. I've also taken care of some poly families that have more than 2 parents. There's just going to be a lot more diversity in our patients, and so it will behoove us to just start adjusting our language to make sure that we're respecting all kinds of families. So probably everyone's somewhat aware of this. This is the DSM-5 definition of substance use disorder. A person needs to have 6 or more of these. Oops, what have I done here? Sorry, guys. 6 or more of these in order to qualify for a diagnosis. I just kind of ran this quickly on myself and coffee, and I have 7 of them. So sometimes our definitions are they go a little overboard, in my opinion. So, as far as pregnancy and substance use, the problem is not drugs. The problem is the cycle of oppression and social determinants of health, which is a term that we've already heard today, which makes me pretty happy. So things that cause problems for parents and for babies are despair, poverty, violence, stress, and systemic barriers. So systemic barriers doesn't just mean barriers to accessing healthcare, it means barriers to employment and housing and education, transportation, all kinds of things. These social determinants of health lead to increased morbidity and mortality, and they also lead to increased newborn opioid withdrawal. Perinatal substance use rarely starts during pregnancy, and so I think that's really important to state explicitly, because a lot of times we have this feeling like, oh, well, she shouldn't be doing that while she's pregnant. It's not like she got pregnant and then was like, oh, hey, I think I'm just going to go out and score some heroin. No, she's already in this situation, there's already dependence, and then the pregnancy comes. Normal patterns of substance use are intermittent. A lot of people have times where they're sober and then they go back and then they go back and forth. That's normal, and so that's very likely to be the case for your pregnant patients. So you can ask them, well, what's worked for you in the past? Because most people have tried to at least change, if not entirely stop, their substance use at some point or another. For femmes in particular, by femmes I mean people who are born with uteruses and vaginas. For femmes in particular, history of trauma is frequently associated with substance use. I don't think I need to go into that too much because that's been very well covered. Another thing that I want to point out is that substance use is often adaptive behavior. So if you have so much trauma sitting on your shoulders that you can't get out of bed in the morning and that you're completely incapacitated, and taking heroin or meth or Zoloft or whatever it is makes you able to function and go about your day, that's adaptive behavior, at least in the beginning. So now we're going to get into the effects of various substances section. Alcohol, I think everyone is pretty familiar with, fetal alcohol syndrome. Alcohol alcohol is by far the most harmful substance that you can take during pregnancy for the health of your baby. Poor nutrition will be on every single one of these slides because pretty much every time you have a substance use disorder, whether it's an upper or downer or whatever, it's going to affect your nutrition either by decreasing appetite or decreasing intestinal motility, or both. Alcohol also comes with a higher risk of accidents just because of decreased coordination and also decreased decision-making ability. Sleep disturbances, liver involvement, which we know can be dangerous in pregnancy. As far as lactation, pump and discard is what we recommend, and that should be for 2 hours per drink minimum. If you had 6 drinks and you waited 12 hours and you feel hungover and horrible, wait until you feel better. Fetal alcohol syndrome is difficult to predict and diagnose. It does not seem to be dose dependent, so the heavier drinkers don't always have the babies with the most severe symptoms. We sometimes see a developmental delay. Babies are usually smaller. The facial anomalies that we all can recognize do fade with time. That's the only aspect of it that is not permanent. Tobacco is the second most harmful substance that you can take while pregnant. We see all those kind of same things that happen with people who smoke who are not pregnant. Increased blood pressure, respiratory problems. There is a kind of a hierarchy of risk with tobacco and nicotine products, and I just very much, I made it a lot smaller for this slide, but smoking is the most harmful, then chewing, and then vaping, and then of course gum and patches and stuff like that. Most of the health problems that are caused by tobacco products are not related to nicotine. And I see a lot of literature, especially about smoking in pregnancy, that assumes that the nicotine exposure is the problem. Nicotine is active. It does increase blood pressure and do some other things, but as far as adults, the health risks are related to other things involved in smoking and chewing and some of the adulterants and such. We see multiple pregnancy complications with tobacco. I won't go into that here. Breastfeeding is indicated with tobacco. Every major Leche League and ACOG and AP, everyone says it is better to breastfeed while smoking than to formula feed while smoking. Obviously, in the perfect world that we all live in, it's best to not smoke while breastfeeding. But the benefits of breastfeeding definitely outweigh the risks associated with smoking and breastfeeding. As far as babies, we get low birth weight. There's an increased risk of SIDS, which is not insignificant. We also see increased asthma and respiratory allergies as children get older. Failure to thrive, which mostly is failure to gain weight, which can be related to low milk supply on mom's part or that decreased appetite on baby's part. There is emerging evidence of a withdrawal syndrome for babies with tobacco and nicotine products. It's not entirely cohesive at this point yet. But we do see tobacco seems to aggravate the withdrawal experienced by babies with other substances. So stimulants. With stimulants, I'm mostly talking about cocaine, methamphetamine, and caffeine. Again, we see poor nutrition, increased blood pressure, infections if injected or smoked, because pipe sharing, especially with methamphetamine or crack cocaine, you get really dry mouth, and it's very easy to have micro cuts in your lips and gums. And so we know there's one study out there about Hep C transmission via pipes. So it's really important to educate people to use their own pipe. As far as breastfeeding, the current recommendation from just about everybody is not to breastfeed with cocaine or methamphetamine. There are a few studies out there that show that if you pump and discard for 24 hours after cocaine or 48 hours after meth, that the baby is fine and safe. I think the reason that we don't recommend that to our patients is because we don't trust them, not because it wouldn't be effective. Breastfeeding is indicated with caffeine, according to the WHO. As far as long-term and baby effects, there's no good evidence of any long-term problems with stimulant use. We have a lot of studies with all of these substances that show associations, which is not the same thing as a causal relationship. So when we control these studies for things like maternal age and education and income level and trauma experience, we see a lot of those effects go away. So a lot of times when we're studying the effects on the infant from substance exposure and we don't control for those things, we're not actually studying substances. We're studying a marginalized population of people that we caught. We know that we're not aware of all of our patients that are using substances because the people that are managing their lives, they're getting good nutrition, they're showing up for their prenatal appointments. We don't catch them. We only catch the bad outcomes, and we oftentimes only surveil the people who are poor and single and brown. And so we get these skewed results that may not necessarily be the results of the substance use. We do see some decreased growth with stimulants, which is probably related to the high blood pressure and decreased placenta, and also decreased appetite that can come with chaotic stimulant use. There is no link to abruption established in the literature with methamphetamine. There is one with cocaine, and I've read a lot of that. Most of the major organizations have said, yep, we know it, it's true. But I just couldn't let it go, so I followed up on all of their citations. You can see I put a handful of them there. And none of those studies really did a very good job with controlling for the other variables that I was talking about, the socioeconomic factors. So there's a link, but I wouldn't call it a causal relationship myself. The effects of illicit stimulant use seem to be similar to very high dose caffeine. So stimulants work in pretty much a similar fashion. They increase our heart rate and our blood pressure, and they make us feel awake and alive. And so when we look at people who are taking their ADD medication, for example, while they're pregnant, their babies are pretty much fine. When we look at people that drink coffee or energy drinks or whatever moderately, their babies are pretty much fine. When people are taking any stimulant in extremely high doses and they're not sleeping and they're not eating and they're constantly just like amped up, that's when we see some issues. So I wanted to just stress that there's nothing special about methamphetamine or cocaine as opposed to other stimulants that are legal and prescribed. And by the way, probably some people know this, but methamphetamine is prescribed to children, I think as young as 6 years old, and adults for ADD. It's not some boogeyman, it's a medication that people use. Cannabis is a fun one. With increasing attention on cannabis as legalization and medical cannabis progresses, there's a lot of attention right now. What I'm seeing in the literature is tons and tons and tons of new systematic reviews and meta-analyses, but not a whole lot of new original data. So that can be problematic, especially with cannabis, because the supply and the products available have changed so rapidly since most of this data was collected 30 or 40 years ago. At the time, we were getting most of our cannabis from Mexico. Most people were rolling it with tobacco in a spliff or a joint. And these days, especially in legal states, which I'm from Washington, so I've seen it firsthand, you go into those stores and they have everything labeled. You know how many milligrams you've got. You can eat it, you can drink it, you can rub it on your sore joints. Research is not keeping up with what's happening right now. So it's an area that we can do a lot more research. We do sometimes see poor nutrition with people with cannabis use. I suspect it's because they're eating a lot of gummy bears and stuff like that, and not actual food. For most people, cannabis has a calming effect on GI symptoms, but for some pregnant people, we do see a paradoxical effect. It's a pretty small percentage of the total pregnant population, but it can happen. Sometimes people come in with hyperemesis and we can't figure out why, and then they're in the hospital for a couple of days not using cannabis, and all of a sudden they're better. So that's something to keep an eye out for as well. I put may decrease milk supply because you're going to see that in almost every meta-analysis and every commentary on cannabis and pregnancy and breastfeeding. That is based off of a study from the 80s, I think 82 maybe, and it was a study that was done on 16 people who were female people who were not lactating, not pregnant, they were not postpartum. They found decreased levels of prolactin, which stimulates your milk supply. So making that jump, I can see the logic of it, but it's a really big leap from decreased prolactin in non-lactating people to decreased milk supply. So that should be taken with caution. As far as I'm aware, that research has not been replicated in 30 years. We got that 16-person sample and we're like, okay, we're good now. We don't need to do anymore. Breastfeeding is not strictly contraindicated, and this is somewhat of a recent development. Probably everybody is familiar with Medications in Mother's Milk, Dr. Hale. The new edition that came out, I believe, earlier this year, it has moved from an L5 to an L4, which I think is in the right direction, but probably not far enough. There's only 2 studies that we have in the English language, as far as I'm aware, that try to separate the effects of pre- and postnatal cannabis use. And one of them found no differences whatsoever in any of the baby's developmental markers, and the other one found, it was pretty cool, it found better scores with people with moderate cannabis use, and then the middle was people with no cannabis use, and then lower scores were people with higher cannabis use. However, all of the scores for mental and motor development were pretty much similar. On one of the measures, it was it's a scale of 160, and it was between 97 and 103. So there were statistically significant differences, but not really clinically significant. And that's another thing to watch out for when you're reading studies. There was one about cannabis and birth weight where they said there's a significant birth weight decrease in people who use cannabis. It was statistically significant, but it was about 30 grams. So for most babies, who cares? The baby's 7 pounds 6 ounces, or it's 7 pounds 7 ounces. It's fine. When we look at very low birth weight infants, that of course can be significant, but cannabis has not been found to increase the incidence of low birth weight, SGA, IUG, any of that. As far as babies, there's no good evidence of any severe lasting negative effect. There is some poor quality evidence of some associations. There are a few studies that find temporary disturbances, like some studies find jitters, some studies don't find jitters. Even the ones that do find jitters, they're gone by, I think, 4 months of age. So we really don't have any good evidence about that. As far as studying pregnancy and substance use in general, our evidence just sucks, because it's really, really difficult to design a study where you give your study group a potentially harmful substance and be like, we're going to just see if this hurts your baby. You cool with that? Our ethics review boards will never let us do it. So we kind of have to look at people who are already using substances, and again, we end up with that problem that the people that we know about tend to be the people that we have caught, which means that they usually have a lot of poor social determinants of health. So all of the data has to be really looked at in context, otherwise it doesn't make sense. Opiates, the one you've all been waiting for. For grown-ups, poor nutrition, constipation, because of that decreased intestinal motility is a problem. And constipation is one of the effects of opioid use, ironically. ironically, that you don't get a tolerance for it. So you don't get less constipated as you get tolerant to opiates. You just keep getting constipated. Overdose is possibly is definitely the most severe effect of opioid use. We all know that it's increasing rapidly. I just want to plug naloxone. I'm not totally sure about y'all's laws here, and you got it? Good. Everyone should have naloxone. Oh, that's right, Matt said that. Everyone should carry naloxone. I carry it. It is impossible to abuse. If you give it to somebody who just passed out and they're not overdosing, it doesn't do anything. They're fine. Even if, when you throw somebody into precipitated withdrawal who was overdosing, it wears off very quickly. It's extremely safe. It used to be extremely cheap. Now it's still really cheap. So everyone should have naloxone. Other things that you can teach your patients are don't use alone. When you get a new batch, have at least 2 people. One person uses first and then waits a minute. Because if you both slam it at the same time, and then you're both going to go out at the same time. Well, roughly the same time usually. So don't use alone, have naloxone, know where it is, make sure your loved ones know where it is. Infections if injected, of course. Not so much with smoking opioids. It can depend on what kind of a pipe you use. A lot of people will use something more disposable, like a really fat straw, or like a toilet paper roll or something like that, so it doesn't get shared as much, but it still can. Gold standard for treatment in pregnancy and otherwise is medication. And it's not just straight up medication, it's medication-assisted treatment. And we're going to go over that a little bit later. As far as babies, we have NAS. That's funny, I forgot to change it to now, you guys. So I like now better because NAS doesn't really say that it's opiates. And I think that's really important. Several years ago, we had this baby. Mom said she only used cocaine. Baby and mom only tested positive for cocaine. And we gave that baby morphine for weeks. And so it's really, really important to just put it out there and say, this is something that happens with opioids and not with other classes of drugs. There's no evidence-based withdrawal that has been established for other classes of drugs. We know from treating babies that are ventilated and stuff that with the phenobarb and the benzos that there is something there. However, it hasn't really been rigorously defined by the literature at this point. Newborn symptoms are difficult to predict. They are not dose dependent, so we don't really know who's going to get it and who's not. One thing to keep in mind about this is that it's temporary and it's treatable. So, and another thing is it doesn't happen immediately when the baby's born. A lot of times in the media, you'll see these things where it implies that babies are just born screaming and shaking and freaking out. And so it's important to make sure we all know that this comes on gradually. It can be, you can spot it, you can see as it progresses, and you can catch it and start treating if necessary. What I have found is that every baby whose parents are prepared and who know that they're going to need to hold that baby 24 plus hours a day, they're going to need to have a dark room and limit visitors, those babies do better. So sometimes when we hear statistics earlier, like how, I forget what it was, 50 to 90% of babies that are exposed need treatment, that is partially because our hospitals are oftentimes the worst possible environment for a baby with this condition. They're bright, and they're noisy, and they're busy.
It is all of our responsibility to harass and nag and email and just bother our administrators and our hospital managers to create spaces that are conducive to parents being with their babies. Because when you have a parent that is able to hold their baby constantly, they do so much better. I had one a few months ago, and it was beautiful to watch. This woman held her baby 24 hours a day. She even held him while she was on the toilet, which it was helpful that she had a natural childbirth and she was able to do that. But that baby went home and did not end up needing any pharmacological treatment. So it really is just such a powerful intervention to be able to have those parents with their babies. One thing that healthcare providers are often not aware of is that the fact that newborn opioid withdrawal is temporary and treatable means we have no good evidence of any long-term problems with these babies. They come in, we watch them and observe them, we assess them. If they need treatment, they get treatment. After they're weaned, they go home and they go on to do just as well as their peers. What we do see in the literature sometimes is associations with negative outcomes. Even the associations with negative outcomes that we do see in the literature are extremely subtle, and most of them, if they were properly controlled for socio-demographic factors, would go away altogether. When I say parents are the most effective intervention that healthcare providers have at their disposal, I'm not exaggerating. Parents are more effective than morphine, they're more effective than a quiet dark room, they're more effective than clustering care. When a parent is able to hold that baby constantly with frequent breast or chest feeding, they do better. Every baby I've ever seen that has gotten out of the hospital quicker or hasn't even needed pharmacological treatment has had nearly constant contact with one, both, or more parents. We can't overstate the value of the primary caregiver knowledge and experience. So that means initially we as healthcare providers, we know more about the mythical average baby, but very soon after birth, those parents know that baby intimately, and we cannot overstate the clinical value of that love and also that symbiotic relationship, because the baby needs the parent and the parent needs the baby. They both do better clinically, emotionally, mentally when they have the other one with them. So when I talked earlier about making sure that we create spaces that are conducive to the family remaining together, that is so, so important, because it's really, really scary for any parent to come into a NICU and to hold their baby. It's particularly scary when they're feeling a lot of internalized guilt and stigma, and they're feeling a lot of judgment from healthcare providers. So not only is it really important to create physical spaces, but also to create welcoming environments, and only staff can do that. For decades, we've known that the best practices for pregnancy and for anybody with opioid use disorder is medication-assisted treatment. A lot of times, healthcare providers feel a little frustrated with medication-assisted treatment because we have this false idea that the point of treatment is to get off opioids, but that's not the case. The point of treatment is to mitigate the negative effects of substance use disorder, which are death and infection. The point is to stay alive, not to become opiate-free. We also see that with medication-assisted treatment, people are able to achieve stability in their lifestyle. So that means rather than wondering where their next dose is going to come from and spending a lot of time every day trying to get money or trying to get their next dose, they're able to focus on other things and work on some of the underlying issues that drove their substance use disorder in the first place. Even if a patient on medication-assisted treatment is still using other drugs, it's still better. Any decrease in illicit substance use is better, and if they're using other drugs, that likely means that they need their dose to be increased. Medication-assisted treatment means that there are other interventions, not just medication. So if we're just treating the physical dependence, we're ignoring all of the underlying factors such as trauma and poverty and despair and fear and stress that lead to substance use disorder in the first place. We have currently methadone and buprenorphine, which for parents, either one is fine. Methadone generally works better if the parent has a higher opioid need each day, and buprenorphine works better if they're taking less. Either one is fine. Whichever one they're on when they become pregnant, they should be maintained on while pregnant. There is some emerging evidence that babies who are exposed to buprenorphine do a little better than babies who are exposed to methadone, but we have to remember that we're looking at a dyad here. It's not just about the baby. That baby will do better if it has a parent who is healthy. So if somebody's on methadone, we don't want to try to switch them to buprenorphine because we want to do what's going to work for that parent and their recovery. There is some evidence coming out about detox in pregnancy, which for a long time we have thought wasn't safe. I still kind of think it's not safe. It's been shown to be safer than we thought, though. There are lots of problems with those studies that are coming out, however. A lot of them are done on incarcerated patients who did not give consent, and they do have really high rates of preterm birth and fetal death as well. So we need to do a lot more research, and we need to do it carefully. One thing that really terrifies me about this research is the thought that it could lead to coerced or even forced detox during pregnancy, which is not going to be good for anybody. The treatment modality that is going to work the best is something that the patient chooses for themselves. So I'm happy if detox is on the menu of treatment options, but what I really, really want to make sure that we're not doing is saying, this is the best thing, you must do it. One size doesn't fit all. We know that from all substance use treatment. We need to make sure that whatever we're doing with the patient, they have a choice and they have motivation, because otherwise it's just not going to work. We hear a lot of talk about how people with substance use disorder are difficult patients, or they're manipulative, or they lie, or they don't trust us. There is a reason for that. Especially with people of color, if you look back at the history of healthcare providers, we have not been doing no harm. The Tuskegee experiments intentionally infected black men with the syphilis virus so that we could study them. There has been sterilization without consent or even knowledge of indigenous women up until the 1990s. When we do universal screening of blood and urine and other body fluids in OB, we are destroying what little trust we have with this population anyhow. Even though it may happen infrequently, people hear stories of going to the OB office and then being taken directly to prison or involuntary commitment in mental health treatment or substance use inpatient treatment. When people hear these stories, it makes them not want to trust us. They also know from personal experience as being substance users that when you go to the doctor, they're not going to be nice to you. They're not going to give you pain medication. I've heard just dozens of stories of people going to the doctor to have an abscess lanced or for some other kind of painful infection, and they're given no pain medication. People who use opiates still feel pain and still need pain medication, even if it's at very, very large amounts in order to be effective. We need to treat people's pain. The very most important thing we can do with these patients is create a trusting therapeutic relationship, and there's no way to do that if we are collecting information to be turned over to the police or to Child Protective Services. We must create an environment where they trust us, and in order to do that, we need to treat them like we treat anyone else. Treat their pain, believe them when they tell us things, and then we can work together to fight their health problem. Instead of us versus them, let's have it be all of us versus their healthcare problem. There isn't any data about the quality of care received by patients who use drugs in hospitals. There is, however, excellent data about other marginalized populations, particularly marginalized racial populations. My logic is, if we treat people who are brown or black worse in hospitals, how much more worse do we treat people who use drugs, who are hated and despised in our culture? Some of the data about brown and black patients comes from a study that came out this year. It looked at 134 NICUs, 18,000 patients in the state of California, and they found that across the board, patients who were brown and black received worse treatment than their white counterparts. So this tells us our good intentions are insufficient. If you tell yourself, oh, I'm not a racist, so I'm fine, I don't need to work on this, that is not accurate. Good intentions are not enough. All of us have been taught to be racist from the moment we were born. When I gave this presentation in Louisville, I kind of chickened out and I just said I have racist tendencies, because it's really hard to look out at a group of hundreds of people and say I am a racist. But it's true, I am. It's embarrassing and I hate it, and I have to fight against it every single day, and so do you. We all have to root out the seeds of racism in ourselves, otherwise we will never fix this problem, and we have no hope of fixing the systemic racism that's inherent in all of our hospital systems. There are hundreds of statistics I could have put on this slide, but instead I chose this one from the CDC that just shows the different rates of maternal mortality based on race. So as you can see, if you are a black woman delivering a baby in this country, you are twice as likely to die as your white counterparts. And that's something that is all of our responsibility, and we should all be ashamed of our systems and work for change. We are all obligated to fight injustice in general and in particular situations. It's not going above and beyond for your patients. This is the bare minimum that is required by us of our association's codes of ethics. The American Nurses Association says nurses must be alert to and must take appropriate action in all instances of unethical practices or actions that place the rights or best interests of the patient in jeopardy. The American Medical Association says that OBGYNs or doctors must examine their own practice to ensure that inappropriate considerations do not affect clinical judgment. They must also work to eliminate biased behavior towards patients by other healthcare professionals and staff who come in contact with patients. The National Association of Social Workers says social workers challenge social injustice. This is all of our responsibility to keep ourselves and our coworkers accountable for the care that we're providing to marginalized patients, and particularly patients who use drugs who are in a very vulnerable position. Okay, so where do we go from here? How do we create welcoming environments for families and root out injustice in our systems? Part of it is language, like we talked about earlier. Part of it is when that family comes in to seek prenatal care or to visit their baby in the NICU, they are terrified. They're terrified that you're going to be mean to them, that it's going to hurt. They're also terrified that they're going to lose custody of their baby or be imprisoned. So the first thing that you can do when you see them walk in your door is give them a big smile and say, "I'm glad you're here. You're doing what's best for yourself and for your baby. Thank you for that." There's also a really great program coming out of the NPA. It's called NIPU, which is the Neonatal Intensive Parenting Unit. There are going to be trainings for staff coming out. There's a whole bunch of articles that are published in the Journal of Perinatology about creating this environment where parents are not just extra. They're not just in the way. They are partners in their baby's care. That means they're partners in providing care and creating care plans, and we value them and we want them in our NICUs. Signage is really important. The way we use language and the way that we put things on signs in our offices and in our NICUs signals to our families whether they're going to be treated with respect or not. Setting realistic goals and expectation for staff and parents is so important. Oftentimes I'll have moms deliver babies and they'll say, "Oh, well, the people at the methadone clinic told me that my baby wouldn't have newborn opioid withdrawal." And so it's really important to make sure that families have an accurate picture of what's going to happen. And that doesn't just mean a negative accurate picture. It means telling them this is temporary and treatable and your baby's going to be fine after the treatment is finished. It's also really important to set realistic expectations for staff. When staff expect parents to be perfect and superhuman, it sets everybody up to have a bad relationship. Staff need to be prepared for what is a normal course of recovery from substance use disorder, which includes relapses, which includes emotional breakdowns. This is a really hard time in our patients' lives, and when we expect them to not have any issues and any problems as they move forward through their journey, that's unrealistic and sets staff up for frustration as well. Another thing that we can do to create these environments is protect our patients' privacy. That means physical privacy. A lot of people with substance use disorder have histories of trauma, and that means they might not like it if you just walk in and open up the gown and grab their breast to help them with breastfeeding. You're going to need to ask what is appropriate and make sure that you tell them what you're going to do before you touch their body. Another thing that we need to do better at is protecting the privacy of people's healthcare information. Oftentimes, it's a salacious story and everyone wants to know about the NAS baby, and that's not okay. I've become a little unpopular at work in the past because sometimes people will come and ask me, "How's that baby doing? What's the mom like?" And if they're not involved in that baby's care, I say, "I'm sorry, but that's not any of your business." And we need to make sure that we're protecting people's healthcare information because when they hear us talking about someone else at the nursing desk, they know that as soon as they leave, we're going to start talking about them too, and that also creates distrust in our relationships with our patients. There are so many programs around the country and the world that are doing things right. I don't really have time to get into detail about all of them, but you can look these up or you can contact me and I'll send you some information. First Square in Vancouver, Canada, with Dr. Ron Abrams, has been doing treatment of mom and baby in the same room for years, and they're having excellent outcomes with decreased lengths of stay, decreased cost, and decreased pharmacological treatment. Dr. Watchman in Boston has such a great quote where she says, "I couldn't care less how many times they yawn." And what she's talking about is how the Finnegan score that we're all used to is really archaic, and it's not helpful any longer for moms and babies. When Loretta Finnegan developed it in 1977, our NICUs looked a lot different. It was a big room with a ton of babies, and it was bright, and it was really not a very good environment. And there were nurses with clipboards keeping track of how many times babies yawned or sneezed and how often they were awake. And really, we don't see that anymore. NICUs are moving to more of a private room setting where you're not going to even get an accurate number of how many sneezes or yawns, or necessarily even if they're sleeping. If it's quiet in there, I'm not going to go in there and disturb that baby. In Hawaii, there's a really successful program working with women who use meth. In Edmonton, Canada, they have a program that's outpatient where they actually partner with their child protection workers, which creates better outcomes for moms and babies. In Edinburgh, Dr. Mary Hepburn for decades has been getting shorter lengths of stay and decreased pharmacological treatment. What all of these programs have in common is that they are not necessarily looking at some arbitrary score. They're looking at, does the baby eat, does the baby sleep, is the baby consolable, and are they gaining weight? Another issue that we can have with the scoring systems we currently use is inter-rater reliability. I've seen so many providers become really frustrated because the baby will be doing one thing and then there's shift change and all of a sudden the scores are very different. Even in facilities where we have trainings yearly to try to get that inter-rater reliability closer, we still are unable to do it because there are words in the scoring system like excessive or high-pitched. What excessive and high-pitched means to me is going to be completely different from what excessive and high-pitched means to you. So it works better when we have something that is concrete and not controversial at all. Is the baby eating, sleeping, gaining weight? This next slide is just a quick introduction for the project that I'm the chair of at the National Perinatal Association. We're working on a national guideline for hospital care of families, childbearing families who use drugs. We aim to have a piece for families, a piece for clinicians, a piece for lawyers and social workers, and also a piece for hospital administrators, because we need to be doing the same thing. We need to be doing best practices everywhere in the country that these patients are being seen. In preparation for our upcoming revised position statement on people with substance use disorder in the perinatal period, we've put out a bunch of memes for Facebook that talk about what our position statement is. We've also developed a bunch of infographics that can be used in offices, online, in social media, that just talk about how we should be talking about and caring for these families. Really quickly, I want to go over some resources for people. Harmreduction.org is the Harm Reduction Coalition website, and they have so many resources available, from book, they put on a conference every 2 years, you name it. Advocatesforpregnantwomen.org is the National Advocates for Pregnant Women website. They provide free legal advocacy and support for marginalized pregnant and parenting women. Nationalperinatal.org/substance use is the NPA work group that I mentioned earlier. The NIPU staff training is coming soon, and you can look at some of those articles at the link provided here. HopeandRecovery.org is a really, really great resource because you can just type in your zip code and it'll find you the nearest overdose prevention program as long as one exists in your area. Please feel free to contact me for these or any other citations or resources that you might have interest in. I've got a lot of them. Thank you.